Thank you, Dr. Khanna. Wonderful conference. And I must appreciate Dr. Khanna's efforts to host this wonderful conference. And a lot of regards for his father, who had been my teacher also in my medical school. So I'm going to give you an overview of the diabetic foot, what an endocrinologist are basically doing in their diabetic foot clinic. And we have a dedicated diabetic foot clinic in our hospital. And we do collaborate with the vascular surgeon like Dr. Khanna in salvaging the most of the limbs. And in diabetic patient, when they come to us initially for screening. Let me start with some of the facts of the diabetic foot. You know, the diabetes is the most common cause of non-traumatic lower limb amputation. And you'll be surprised to know that every 30 seconds, a limb is amputated due to diabetes somewhere in the world. And more than 80% of amputations are preceded by a foot ulcer. So these are some of the facts. And you know, Dr. Khanna told you some of the risk factors about the diabetic foot. Predominantly are the male sex, long duration of diabetes, peripheral neuropathy, abnormal foot structures, peripheral arterial disease, history of smoking, any history of previous ulcers or amputation, and of course, uncontrolled blood sugar, a poor glycemic control if the A1C remains persistently above 7. To give a brief idea of the underlying pathophysiology, it is primarily because of the underlying sensory motor neuropathy and the autonomic neuropathy. Autonomic neuropathy is important for causing the reduced sweating, dry skin, fissure and cracks, and which leads to the infection, while the sensory and motor neuropathy will cause the muscle wasting, foot weakness, decrease in the proprioception, unaware of the foot positions, again a callus formation, deformities, stress and shear pressures. Ultimately, the trauma leads to the ulcer with the superadded infection, and which is the story that we are dealing in our day-to-day cases, what we see. Now, how an endocrinologist should go for an approach when any patient with the diabetic foot comes. We have to take a good history of the risk factor for the ulcerations, and there are no risk factor. You have to give proper general advice to the patient, which most of the doctors are lacking because of the lack of time. A good nail care, hygiene, footwear, and podiatry are must for prevention of the diabetic foot amputation in the near future. And we had to review the risk status at least annually. It is mandate to say the moment the patient enters your clinic with the diabetes, you have to examine his foot, tell him to remove the socks and shoes. Without that, no examination of a diabetes is complete. Otherwise, you're going to miss many, many lesions of the diabetic foot. If the patient has plenty of risk factors, you have to do, apart from the foot care education, a regular podiatry, possibly advising him to special footwear, and much more frequent review, always inspecting the feet at every visit.
राधे राधे। मैं
Patient
मीटिंग में के
evaluations.
बीच में हूँ, मैंने दोपहर में भी
Patient evaluation basically includes history, the foot specific history, what kind of a footwear patient is wearing, whether he's having any callus, foot deformities, or any previous foot infection. You have to take detailed symptomatology of the peripheral neuropathy, what is having claudication or not, and also the history of the wound and ulcer history is important. These are some of the important bullet points when you try to elucidate the wound or the ulcer history. Now, the best thing to see the dermatological, musculoskeletal, neurological, and the vascular assessment, the important is we had to do all of them the moment the patient comes to a clinic. Vascular assessment is important. Foot pulses, ankle brachial index, toe brachial index, and Doppler of the distal arteries is very important, what we are doing routinely in our clinic. Then neurological, using the 10-gram monofilament, vibration, pinprick sensation, ankle reflexes, and the vibratory perception third VPT. Musculoskeletal is simply the examining the muscle wasting and whether the patient is wearing a appropriate size of the shoes or not. And of course, dermatological changes like looking at the loss of sweating, any infection, any change in the color of the skin or dryness. Now, the infections when the patient present can be a simple cellulitis when we present with a tender erythematous non-raised skin lesions, no ulcer. It can present as a deep skin and soft tissue infections like ulcers, fall discharge and gangrene, and ultimately some of the patient present with the deep ulcers, the sinus tracts leading to the osteomyelitis. It is important for a physician to basically differentiate between neuropathic ulcer and the ischemic ulcers. And the neuropathic ulcers are patiently of the younger age group, the ischemic ulcer of the older age group when they have the what you call the established atherosclerotic cardiovascular disease, pedal deformities, color of the skin is important. Ulcer features in the ischemic ulcer, they are cool, often red, dry, black, often located on the dorsal surface of the feet and toes, and the pulses and the pain. Normally in the neuropathic ulcer, what we call is sometimes known painless neuropathic ulcers, but often we see in the ischemic ulcer patient complaints of the pain. Now, when we talk of the demystifying the diabetic foot, we have to remember that every patient with diabetes who present with a diabetic foot is not always a diabetic foot. There can be some other infection which we have to keep in our mind to basically distinguish this diabetic foot infection from the other commonly infection what we come across. Because the patient is diabetic doesn't mean that this foot ulcer is caused by the diabetic or uncontrolled diabetes. You can see that the most of the diabetic foot infection imposters. On top of it, you can see a patient's diabetic who presents with the pyoderma gangrenosum may be missed as a diabetic foot. Erythema nodosum in the initial stages may be missed as a diabetic foot. Then necrobiasis, dipoidica, diabeticora. Venous ulcers in patients of a diabetes may not be a typical diabetic ulcer. And to my surprise, a non-healing ulcers on the plantar aspect of the head of the first metatarsal, which was being treated as a diabetic foot ulcer. When we did the biopsy, it came out to be squamous cell carcinoma in a chronic ulcer, what we call the marginal ulcers. Even simple superficial thrombophlebitis, diabetic bully, and malignant melanoma can be missed, and we just think, and this may be diabetic. Even rat bite, sometimes the rat bite in patient of the diabetes, when they come, you just present with the ulcer, and one of the common cause may not be directed to diabetes. It may be a rat bite, which is very common in a country like ours. Of course, the holistic management includes a good glycemic control, preventative foot care, a diabetic foot ulcer care, ischemic management, neuropathy management, and of course, the surgeon's role in managing the diabetic foot. We know the prevention is better than cured. There are 12 key steps to the diabetic foot health, which I have enumerated here. You have to look and feel inside your shoes before putting them on every day. And these kind of posters we keep in our clinic for every patient to read in the waiting room and when the patient is waiting for the doctors. And these simple illustrations in the form of a sort of a board, the patients continue reading and then come to know what are the important facts. Now, I will tell you, debridement, dressing, offloading, and control of infection are the 4 key components of the diabetic foot management. Debridement, good dressing is important. Control of infections are important. And these infections are the control based on the culture studies, what kind of antibiotics we have to use, and the offloading. Offloading important. You can use total contact cost, you can use crutches, you can use wheelchair, you can use offloaded shoes and everything. In fact, we are giving offloading insoles, foot insole, which is manufactured in-house in our diabetic foot clinic, which I am going to show what we do.
Dr. Wangnoo, sorry to interrupt. So you have 1 minute left. Kindly.
Yes, I'm just continuing 2 more slides. You can go for the WAC negative pressure wound therapy, hyperbaric oxygen therapy we do have in our hospital, growth factor therapy, and some people use the living skin equivalent grafts. Stem cell therapy, we heard excellent lecture from the previous speaker. We really have know that what is being done in the stem cell therapy. And this part, what I am going, ischemia neuropathy, we leave to the our vascular surgeons for the angiography, CT angiography, and to salvage the limb if they require any angioplasty or the bypass surgery or the removing the blockage if the patient has a blockage. To conclude my talk, nowadays, most of the drugs which are being used for diabetes management has to be kept in mind because there are certain drugs which has got the in-box, black box warning, which can lead to the foot amputation among them. One of the drugs is canagliflozins, which comes under SGLT2, which may be associated with the increased risk of amputations, has to be avoided in patients with history of foot disease or at increased risk of foot ulcer. This is last word of my caution. This is the clinic what we do in our hospital. This is Apollo Foot Clinic. We have educators, we have biothiosymmetry, we have the podia scan, we have the handheld vascular Dopplers, we have the in-house insole manufacturing facilities. We have all kinds of off-roading devices, what we advise to the patient. With this, I thank you all for a kind listening. Please take care of your feet, and that is the feet is telling me, please take care of me. Thanks a lot.
Thank you very much, Dr. Wangnoo. You are wonderful in your presentation and your practice, and it's very, very in a good fortune for us to be, for you to be working in Apollo and we to be working together. I can really tell, the whole success of our diabetic foot program and our revascularization therapy is, because we have Dr. Wangnoo around, we can actually the most complex diabetic foot infections, not only diabetic but other wounds as well. So thank you very much. Thanks for sparing your time.